So our first speaker is Dr. Berman from UCSD. He did his training at UCSD also for IR and DR, and he'll be giving us the talk on the comprehensive management of HCC or hepatocellular carcinoma.
All right. So nice to meet all of you guys. I hope over the next 7.5 minutes or so, I can kind of show you the evolving HCC landscape and kind of all the different interventions we can do. So I recommend buckling up because this is going to be, a lot of information, a lot of trials, and really rapidly. When we look at where we started as a specialty, this is kind of around the 1970s, where we just, discovered that, hey, if we put something into the arteries, we can kill tumors. And so you can see Dr. Yamada here published the first trial looking at 120 patients with unresectable HCC. What if we just did embolization? And as you can see, it was somewhat effective, but unfortunately, it was a 50-50 shot whether you're even going to be alive at 1 year. So hopefully I can convince you over the next 50 years we've improved this number. Every single HCC talk is going to start with the BCLC guidelines. It's very complex and there's a lot of stuff going on, but more importantly, I want to have you guys focus here on this line because this is where it kind of talks about not only the therapies that we offer, but also what our expected goals of treatment are. So for the earlier stage diseases on the left-hand side, we're expecting an overall survival of greater than 5 years. And as we get to more and more advanced disease, the overall survival becomes, less as well. And you can see for early stage disease, they recommend resection ablation, followed by TACE, followed by systemic therapy as we get more advanced. What does this look like schematically? So earlier stage diseases, you can see we have small tumors. As we get more intermediate, we get more tumors, and more advanced, there's vascular invasion or metastatic disease. And unfortunately, as the patients have poor performance status, there's stage D where there's not much to offer. So let's look at early stage disease where resection and ablation are recommended as first-line therapy. And where does this come from? This comes from 3 randomized controlled trials that looked at radiofrequency ablation comparing to surgical resection for early stage HCC. And you can see the 1-year and 3-year overall survival rates were near similar between the two groups. There's one trial that looked up to 5 years that showed a difference. But based on this, we have good randomized evidence that at least your 3-year overall survival rate is very similar between radiofrequency ablation and resection. When you look at a meta-analysis of these treatments, you can see that it crosses, the baseline of 1. And so there's no definite advantage of one versus the other. So that's, level 1 evidence showing that ablation at least can be considered as a first-line therapy. What does it look like? Here's a tumor that measures about 2.2 centimeters. You can see a nice ultrasound image of our ablation needle going into the tumor. We use microwave in this case, and you can see a contrast ultrasound immediately afterwards showing a dead tumor. This is CT images showing that intraprocedurally we have good coverage. And more importantly, 6 years later, you can see we have a dead ablation cavity that looks stable. So it's a very durable, effective therapy. And you can see with kind of stereotactic guidance, which I think is going to be the future of most ablation, when 200 HCCs that were treated with radiofrequency ablation using stereotactic guidance, the rate of complete pathologic and complete imaging response is getting close to 100%. Very effective therapy. For somewhat larger tumors, there's good randomized evidence that's showing that ablation in and of itself is not enough. So you have to add in TACE and ablation, and you start to get improved not only recurrence-free survival, but overall survival as well. So again, randomized evidence. However, not every single tumor is amenable to ablation. So here's a tumor way up in the dome. I had a biopsy it. This is a very scary biopsy because, it's a big needle. The patient's awake and they're not, very happy about the size of the needle, and neither are you. However, transarterially, this is very easy for us to get to, as you can see here. So in this case, we decided to do radioembolization using a very high dose radiation because we're perfusing only about 3.6% of the liver. And at 3 months, we have a dead tumor. At 6 months, you can see a necrotic cavity developing. And more importantly, at transplant, you can see ablation beads, no viable tumor. There's a good retrospective patient study showing that the durability of this response is 76% at 2 years. And more importantly, one treatment is going to give you, a 94% chance of not having a viable tumor at 2 years. Very important. Where does this fit in the landscape? As you can see here, it's very comparable to both radio frequency ablation and surgical resection. The RAZOR study was a confirmatory study as well. We look at TACE and SBRT for earlier stage disease. Here's a randomized trial published last year showing the overall survival is very similar between those two therapies. And it's at least compared in the randomized trials, less than radiofrequency ablation or ablation in general, resection and TARE. So there's something to consider when you're choosing modalities of treatment. Let's quickly move on to intermediate stage disease. We'll start with TACE. So TACE was the first randomized controlled trials that we really kind of did in this space in the early, right around 2000, 2001, published in Lancet and New England Journal, 2 trials, showing that at least it's better than doing nothing, which was the standard of care up until that point. We've since improved upon that. And so you can see a large retrospective trial of 500 or study of 580 patients done out of Europe. And you can show for at least smaller tumors, so less than up to 7 criteria, we're getting a good 5-year overall survival. But as the tumors start to get bigger, the survival goes down to about 2 years. The TRACE trial was a single-center prospective trial looking at radioembolization versus chemoembolization. It ended up being stopped early because the survival was doubled in the radioembolization arm compared to the chemoembolization arm. So again, showing advancements in the therapy that we have for at least intermediate stage disease. The target study looked at is there a dose response relationship with intermediate stage tumors? And if we give more dose to the tumor, do we get better overall survival? And as you can see in this scenario, if we were to get over 300 gray in radioembolization, the overall survival goes from about that 1.5 to 2 years range to well over 3 years. Again, a huge advancement. So dose matters when you're going to be doing radioembolization, and there's many trials open right now that are going to, hopefully kind of further answer this topic. Moving from intermediate stage disease to advanced disease, if you look at the BCLC guidelines, it's mostly medical oncology. However, I'd argue that we have a growing role in this. And then where did we start? There's 2 trials looking at Y90 with resin microspheres versus sorafenib, published in Lancet and the Journal of Clinical Oncology, both showing that there was no improvement in overall survival by using radioembolization. However, of note, the trials were limited by the dose, as we were talking about earlier. The dosing has improved since this time. And I'd argue if we redid this trials, they'd probably be positive. Why do I say that? Dososphere, which came out in 2021 and just had its further analysis published, showed that for these advanced tumors, 10-centimeter tumors, 64% with tumor in veins, we have markedly improved overall survival. So you can see 10 months in the control arm, which is very similar to the previous studies that I just showed, increased to about 27 months in the personalized or improved dosimetry arm. So much like we saw in the target study, at least we now have prospective randomized evidence to show that the overall survival markedly improved by increasing the tumor doses. I think going forward in the future, we're going to see a lot more combination therapy. This is the first trial that kind of showed that in a randomized fashion. This looked at advanced patients and then combined TACE with lenvatinib. And you can see that the overall survival increased by 6 months by just including TACE in and above lenvatinib in itself. And I think there's a lot of evidence showing that I think we can improve this by looking at combining with immunotherapy. And the question is, how do we sequence this stuff? I think we're going to figure this out over time. And there's many trials open to answer that right now. Most importantly, the EMERALD-1 trial, which just came back positive a couple of weeks ago, showing that there is the benefit of TACE plus immunotherapy, but there's many other trials open right now. So I know that was a really fast whirlwind through all of HCC care, but it's a very evolving field and very interesting. And I want to thank you for inviting me to give this talk.
Thank you so much, Dr. Berman. We do have time for a couple questions if you're able to get them from the chat, Nathan.
Yeah, so I was looking over the chat, and we have a question, I believe, from Dr. Shingawa. How do you do stereotactic ablation?
There's many different products and devices out there on the market. And some, involve robotic guidance. Some involve, 3D localization through different devices. So you can have, real-time fusion between where your probe is and the pre-imaging. There's many different ways of doing that. There's a lot of vendors that create devices. And I think as we have more and more trials coming out looking at this, I think it's going to become the standard of care.
Great, thank you. And the next question in the chat is, could you elaborate on the dose determination WRT treatment planning for Y90 tear?
I think going forward, this is going to also be the standard of care, where we use either the test dose of the Y90 itself, and there's two, the resin microspheres and Holmium both use this right now, or the MAA mapping to calculate a dose to your tumor prospectively, so you can ensure that you get a high enough dose to the tumor in order to get a good clinical response. I don't know if that answered your question, but you feel free to email me and I can elaborate further.
Yeah, and the next question is, what is your take on PFS versus OS for primary endpoint, and what do you tell your patients on how to interpret that?
Oh, that's the $1 million question, right? Because like when you talk to a patient in clinic, they're not going to say, "What's my PFS, doctor?" Their question is, "Am I going to live longer because we're doing this?" So ultimately, OS is the best metric. But as we're starting to make patients live longer and longer and longer, as you can see with five plus years, the trial has become kind of untenable in order to do because it becomes too expensive. So a lot of people have started to look at PFS. I think for ablative type therapies or like Y90, ablative Y90, I think is a reasonable metric. But for TACE, which is designed to be done multiple times, I think it's a poor metric for primary endpoint. But that's an ongoing question that everyone's asking in IO right now.
Okay, and then we have another question. Some trials, like Emerald, looks at the specific patient genotypes. What are the roles of genotyping in current clinical care when it comes to combined systemic and IR intervention?
So at least right now, all of our therapies are pretty agnostic to the type of genotypes of the tumors. Obviously, certain tumor types might respond to different systemic therapies differently. So I think that would be, at least today, as a better question for a medical oncologist. But as we get more involved in kind of transarterial or local regional therapies using immunotherapy, which I think is a growing field, we're gonna have to start to think about that a lot more ourselves. But at least in 2024, it's hard to answer that question.
And then when would you consider doing TACE versus TARE in HCC treatment?
Oh, that is a loaded question. I'm probably gonna get some flack for this. But I would say TACE is for bilobar patients with compromised liver function. If the patient is amenable to radioembolization, I think the evidence is considerably stronger for it. The other option would be if you're going to get them to an ablative therapy with percutaneous ablation. I think TACE prior to ablation would be another time to do it. But I would recommend trying to get them to a true ablative modality or surgical resection, because that's where overall survival is the best.
Great. Thank you, Dr. Berman.
Great. Thank you, guys.